Hello everyone. Welcome to today's webinar on sleep disorders and Bruxism, presented by Dr. Gauri J. Pandya, an internal medicine specialist and a sleep physician. Dr. Pandya will provide an in-depth understanding of sleep bruxism, a condition that significantly impacts both oral and overall health, covering its causes, symptoms, treatment options, and relevant case studies. So with this, we welcome Dr. Pandya to share her presentation. Dr. Pandya?
Hello, good evening, everyone. Thank you for spending your evening hour with me today. And thank you, Dr. Joyce, for the kind introduction. Without any delay, I will just jump onto the topic. Just give me one minute. Okay. So, as Dr. Joyce mentioned, I'm going to present on the sleep bruxism. And we are going through the following things in this presentation. We are going to go through the definition of bruxism, prevalence, classification, bruxism disorder, etiology, pathophysiology, and management, which includes the diagnosis and the treatment. So, next slide, please. Yeah. So, what is the bruxism? So, bruxism is a sleep-related movement disorder characterized by teeth grinding or clenching frequently, but not exclusively associated with sleep arousal. And sleep bruxism has been traditionally considered as an oral parafunction with the involuntary rhythmic or spasmodic non-functional grinding or chewing movement of the mandible. But nowadays, the research is not research is thinking that this hypothesis is not the real hypothesis. We will go through the more possible mechanism later on. Next slide, please. So, prevalence-wise, there was a systemic review done by Manfredi et al., and he found that the prevalence is between 8 to 31% in the general population. And he used the questionnaire such as the oral behavioral checklist, and the question, are you aware of clenching or grinding your teeth during sleep? Next slide, please. Yeah. So, prevalence in Singapore, bruxism is common with a higher prevalence in children than the adult, and prevalence is higher up to 49% in children. In adult, it is varying from 22 to 30%, but in average around 15%, and 3% in the people who are over 60 years of age. The sleep stage in which the sleep bruxism occurs is most important. So usually the garden
Hello, doctor. Can you continue, please?
Yeah, I can continue, but I'm at the prevalence slide. Yeah. So,
Okay.
so sorry for the technical glitch. Now, the prevalence, as we discussed, is higher in the children, and as we grow older, the prevalence is declining, and only 3% in the people who are more than 60 years of age. The destructive bruxism can happen in the rapid eye movement stage of the sleep. Next slide, please. So bruxism classification, when I went through the different literature, they have been classifying bruxism in the different way. So the first way, we are classifying bruxism according to the circadian rhythm, and it can happen in the daytime, which is known as awake bruxism, and it can happen in the night time, which is known as the sleep bruxism. And the both has a distinct etiology, and sleep bruxism has an undesirable sleep-related phenomenon. The International Classification of the Sleep Disorder is classifying bruxism under the sleep-related movement disorder. Next slide, please. So in this, we can see that sleep disorders are classified under 6 different categories, and the bruxism is under the sleep-related movement disorder. Next slide, please. So now based on the grading system, and this is the classification I am going to use frequently in my presentation. So possible bruxism is based on the self-report from the patient's history or questionnaire. Probable bruxism is the same as the possible, plus there is the outcome from clinical examination. And if clinical examination suggests there is tooth wear or hypertrophic jaw muscles, then we call it as probable bruxism, and the definitive bruxism will be the same as probable plus evidence from the polysomnography or the sleep study of having the sleep bruxism, and it is the gold standard technique to find out whether patient has a bruxism or not. And in the daytime, we need to do the ecological momentary assessment by electromyography or the EMG for awake bruxism. Next slide, please. Okay. So bruxism can also be classified based on is there any underlying medical conditions or any medication or substance use can cause it. So primary bruxism usually is when there is no pre-existing medical condition or the medications, while the secondary bruxism is associated with the disorders such as medical comorbidities, substance or the medication use. And the disorders that can be associated with bruxism are obstructive sleep apnea, insomnia, periodic limb movements of sleep, rapid eye movement behavior disorder REM-BD. These are all sleep disorders. Other medical comorbid conditions can be Parkinson's disease, sleep epilepsy, gastrointestinal reflux disease or GERD, and the substances are the anxiolytic, antipsychotic, or antidepressant medications, stimulants such as tobacco or the nicotine use, caffeine, alcohol, or amphetamine, or other such recreational drug use. Next slide, please. So when we call bruxism as a disorder, so usually in the healthy individual, bruxism is a behavior, it's not a disorder. But when the bruxism becomes, when the patient becomes symptomatic with medical or the dental comorbidities, such as headache, orofacial pain, temporomandibular disorder, excessive tooth wear, tooth fracture, or rapid progression of periodontal disease, then we call it as the bruxism disorder. Next slide, please. Yeah. So what can be the etiology or the pathophysiology? So actually, the etiology of the sleep bruxism is still controversial, and it may be more appropriate to talk about the risk factor instead of the etiological factors. And the sleep bruxism has the 3 possible risk factors, such as anatomical, psychological, and the central nervous system factors. Next slide, please. Anatomical factors includes malocclusion, occlusal discrepancies or craniofacial morphology, which can irritate the central nervous system and trigger the excessive jaw muscle activity. But as we mentioned in the earlier slide, that this current experiment is contradicting this hypothesis. And nowadays, evidence suggests that sleep bruxism is considered to be mainly regulated and influenced by the central nervous system, autonomic nervous system, with the psychological hyperarousal factors playing a role as well. Next slide, please. Psychological factor-wise, anxiety, competitiveness, emotional tension, aggressiveness, stress, and maladaptive or the less positive coping strategy have frequently been associated with sleep bruxism. Other thing, which is a neuroticism, which is typically defined as tendency towards anxiety, depression, self-doubt, and other negative feelings, is this neuroticism is also associated with the bruxism. Next slide, please. So, with the central nervous system factor, the sleep-related movement disorder such as restless leg syndrome in the younger age and the rapid eye movement sleep behavior disorder, also known as REM-BD or RBD, in the older age are considered to be the concomitant and a significant risk factor for sleep bruxism in some individuals. Sleep apnea is considered in some individuals and is another significant risk factor for the sleep bruxism. But the link between these two disorder is growing, and the strength of such association is still debated, and causality is still not yet proven. But there is always a thought and the hypothesis that these two conditions are linked to each other. Next slide, please. So in the central nervous system factors, studies have now linked sleep bruxism to the cyclic alternative pattern known as CAP, and it is based on the electroencephalographic, electrocardiographic, and the electromyographic activation every 30 to 60 seconds. And nearly 80% of the sleep bruxism episodes are associated with the CAP. Next slide, please. So there is also a hypothesis that the arousal during the sleep is the genesis of the sleep bruxism. And when we go to sleep, there is a change in autonomic, cardiac, sympathetic, and the parasympathetic balance, causing a rise in EEG activity with more alpha activity, which is an arousal response. And there is a typo in the delta activity. This causes the tachycardia and the increased jaw opener muscle activity with an increase in the respiratory amplitude. And finally, the jaw closing muscles leading to the teeth grinding or the jaw clenching will happen in a rhythmic jaw movement also known as RMMA, which is the rhythmic masticatory muscle activity. This causes the blood pressure rise, and this is the thing which is strongly suggests that sleep bruxism is due to exacerbated transient motor and the autonomic nervous system activation in relation to the microarousal, causing the genesis of the sleep bruxism. Next slide, please. Apart from the microarousal, vibrotactile stimuli and genetic susceptibility are also responsible for the genesis of the sleep bruxism. Next slide, please. So, this is the questionnaires for the temporomandibular joint disorder and the sleep bruxism, and it is the used as a diagnostic criteria for the temporomandibular disorders. Next slide, please. Okay, so diagnosis is usually based on the our grading, which is the probable, possible, and the definite bruxism. And for the probable Bruch scale of the oral parafunction questionnaire has been used. On the top of that, history tracking clinical examination and polysomnography with the bruxism EMG are the gold standard for the diagnosis of the sleep bruxism. Next slide, please. So this is the self-reported bruxism, and this is the definition for the possible sleep bruxism. And we use these following questions, and the patient has to respond in form of never to always, and we come up with the scale in decide whether patient has a possible sleep bruxism or not. Next slide, please. So there is question, if we are relying on the questionnaire or we are using the questionnaires, how reliable they are. So here the author has very nice summary that how we should believe on the questionnaire. So it says that there is a disadvantage of use of questionnaires because approximately 80% of the bruxism episodes are free of grinding sounds. That means patients may not be aware that they are having the bruxism because they didn't have any grinding sound. Only investigation reporting both polysomnographic and the self-reported bruxism diagnosis in the large sample study shows that polysomnographic confirmation of the sleep bruxism in less than half of the patient with the self-reporting behavior. So even the 100 people say that I have sleep bruxism, but only 50 has confirmed sleep bruxism on the polysomnographic evidence. So it is also again not favoring that it is accurate. Further, the occurrence and the severity of the sleep bruxism fluctuate over time, which further hamper the accuracy of the self-reports of the sleep bruxism. And because of the above, author says that it has to be interpreted with the caution and it should be combined with the diagnostic tool. Next slide, please. So in the clinical examination, and as a dentist, you guys are the front line for all these patients. There are two forms of the examination. One is the extraoral and the intraoral. So in the extraoral examination, you can find the masticatory muscle hypertrophy. And in the intraoral assessment, you can see the tooth-induced impressions in the cheek or tongue, tooth wear, fracture or failure of restorations and the implant. And the functional examination of the masticatory system based on the paradigm that the bruxism and the temporomandibular disorder pain are potentially causally related. Next slide, please. Yeah. So this is the images showing the sleep bruxism and the there are two views used in these images, frontal view and the lower jaw. Next slide, please. So what are the instrumental assessment we can do for the sleep bruxism? So polysomnography, the level 1 sleep study. As mentioned before, this is a gold standard test for the diagnosis of the sleep bruxism. And a definitive diagnosis of sleep bruxism can be based on a positive recording, preferably in a combination with the audio-video recording. And in PhD, we have both audio-video recording, but it is expensive and not easily accessible tool. And apart from the routine polysomnography, we are putting the additional to lead on the masseter and the temporal muscle to have the better idea on the bruxism and to classify the diagnostic criteria of the bruxism, which I'm going to talk about later. Other alternative instrument and technique can be intraoral appliances and electromyography. Next slide, please. So PSG findings of the sleep bruxism can be divided into the phasic rhythmic episodes, tonic or sustained episodes, mixed episode, or the non-classifiable burst. Next slide, please. Okay. And usually when we summarize the sleep bruxism, it is in the form of the number of the sleep bruxism episodes per night, number of sleep bruxism episodes per hour, number of sleep bruxism bursts per hour, number of sleep bruxism bursts per episode. Next slide, please. Okay. And what is the diagnostic cutoff criteria for sleep bruxism? So the classical criteria wise, there should be 4 episodes per hour and the 6 bursts per episode and or more than 25 bursts per hour. At least 1 episode per night with grinding sounds. And we have to classify into the low intensity, moderate, and the high intensity. And once the patient classifies this diagnostic cutoff criteria of the sleep bruxism, this is abnormal, and this helps to detect the sleep bruxism and the pathological consequences of the sleep bruxism. Thus, it helps to discriminate the physiologic phenomenon from the treatment needing condition. Next slide, please. So, this is the one of my patients' bruxism report. This patient came to us because he says he has some temporomandibular joint pain. He does grind his teeth, and he also had the symptoms of obstructive sleep apnea. So we did polysomnography, and along with that, we included the EMG electrodes for the bruxism. And his bruxism report is that he has 14 episodes per hour, so which is more than 4 episodes per hour by the classified criteria, 6 bursts per episodes, and he has 14, and there is episode of at least 1 episode per night of grinding sound. So he does qualify the diagnostic or the diagnostic criteria for the sleep bruxism, which are the classical criteria. Next slide, please. Other thing, the last slide was the summary, and there are detailed phasic, tonic, and the mix episode counts, and the summary are given in the polysomnography. Next slide, please. Yeah, and this is whether it is associated with the respiratory events or any arousal. So usually we count according to the phasic, tonic, or the mixed activity. Next slide, please. And we also count along with the apnea hypopnea index and see whether there is any association. Is it related to apnea hypopnea or any arousal related to respiratory event, or is it just without any respiratory event? So this help us to figure out whether it is related to the sleep apnea or not. Next slide, please. So other instrumental technique for the sleep bruxism can be the intraoral appliances and the electromyographic. But there was a systemic review done by the Malfredini et al. And he found that these techniques are giving insufficient data. They are not giving the solid enough data to support these techniques as stand-alone tools for diagnosis of sleep bruxism. Next slide, please. So when we are dealing with the patients of sleep bruxism, what are the things we need to think further? So when we identify that patient has a sleep bruxism, we need to think, do they have any other differential diagnosis such as oral motor disorders, which includes the orofacial dyskinesia and the oromandibular dystonia. Others can be rapid eye movement behavioral disorder, mainly particularly in the elderly people, obstructive sleep apnea, and the gastroesophageal reflux disease. So these are the, we have to specifically ask the patient history and further dig for this alternative diagnosis or the differential diagnosis. If we miss that, we might not able to treat patient properly. Next slide, please. So the sleep disorder breathing and the sleep bruxism. So there is hypothesis that it is correlated with the arousal episode, and as what we discussed in the sleep arousal is as a genesis for the sleep bruxism. And the higher number of the short arousal episodes have been observed in the patient with the obstructive sleep apnea. So with the obstructive sleep apnea, the hallmark of the lot of pathological consequences and clinical consequences are intermittent hypoxia and sleep fragmentation with the recurrent arousals. So are we thinking that this to have the possible relationship? And there has been certain hypothesis which has been mentioned that the findings regarding the temporal relationship between the two phenomena are inconclusive. However, do not allow determination of important clinical questions. Does bruxism like jaw muscle activity actually follow or precede the sleep apnea? Do they coincide, or are the events temporary unrelated? So these are the few things. Still it is unanswered, and the further uh, research studies are going on, and we need the answer from there. Next slide, please. And it can be hypothesized in the 4 different ways. So the first is two phenomena are unrelated with respect to the temporal sequence. The onset of OSA event precedes the onset of sleep bruxism event within a limited time span. This limited time span is not defined as well. The onset of the sleep bruxism event precedes the onset of OSA event within a limited time span, or onset of both phenomena occurs at the same moment. And the most plausible hypothesis is that all of these temporal relationship between sleep bruxism event and OSA are actually possible, and that the relative predominance of one specific sequence of the event may vary from patient to patient. So it may not be the same for all the patients. Next slide, please. So now coming to the orofacial pain and the temporomandibular disorders in relation to the sleep disorder breathing and the sleep bruxism. So quite often patients are not aware of the teeth grinding in the night time, but they are sometimes we need to ask their life partner, and their life partner also not sure. But many patients has a complaint of their temporomandibular joint pain or some ache when they wake up, and sometimes it is so hurting to them that they cannot continue with their daily work or even their chewing movement. So if we encounter such patient, we have to always think, do this patient has a sleep bruxism or the sleep disorder breathing, and the most common is obstructive sleep apnea. So among the chronic orofacial pain conditions, temporomandibular disorders are the most common, and the etiology is multifactorial. But evidence for the obstructive sleep apnea as a risk factor for the temporomandibular disorder is limited at the moment to a few cross-sectional studies reporting higher prevalence of the sleep disorder breathing and the higher prevalence of the temporomandibular dysfunction among the patients with the sleep disorder breathing. So we need the further research to support or to contradict this correlation between these two conditions. Next slide, please. So these are the 5 studies which supports that the sleep disorder breathing is a causative factor for the temporomandibular disorder. Next slide, please. This is a nice study done by the Raphael et al. And he compared the people who has the temporomandibular disorder and the people who are not complaining of any temporomandibular pain or any issues. So the people who has the temporomandibular disorder, they are in the green, and the controls are in the blue. And as we go from the left to right, we can see that there is higher EMG volts and the higher episodes of the bruxism. And this says that there is a sleep bruxism is a causative candidate for the temporomandibular disorder. Next slide, please. So hypothesis, there are two different hypotheses which suggest that the sleep bruxism and the sleep disorder breathings can lead to the temporomandibular disorders. So first hypothesis is that there is elevated background masticatory muscle activity during sleep, which protrudes and stabilizes the mandible, reduces upper airway resistance, and along with that, there is respiratory effort-related arousal causing the temporomandibular disorders. And the next slide, please. And the second hypothesis that discuss that arousal, frequent arousal, and intermittent hypoxia causing the sympathetic hyperactivity, oxidative stress, and activation of the pro-inflammatory pathways causing the temporomandibular disorder. Next slide, please. So apart from this obstructive sleep apnea, there are two more hypotheses, and these are insomnia is common in patients with the temporomandibular disorder, and it's characterized by hyperarousability. So when the patient has a low arousal threshold with a temporomandibular disorder, and they also have the pain, it could evoke the respiratory instability during sleep, and it realized as a respiratory event related arousals or OSA. This RERA is also having the similar consequences as the OSA, and we are now paying attention to these RERAs in the PhDs. So possibility is that the both sleep breathing disorder and the temporomandibular disorders are independent in the settings of unfavorable craniofacial anatomy. So that means the patient has some abnormality in the craniofacial abnormality, which is contributing to both temporomandibular disorder and the sleep disorder breathing, which is most common is OSA. Although the correlation is highly controversial, but some studies have reported that the anatomical risk factor for TMD and the major three factors, which are the retrocranial long or the hyperdivergent phase, are also associated with the OSA. So there is indirect relationship as well. The next slide, please. So apart from the temporomandibular disorder, there is a restorative dentistry in which we need to decide the direction of the tooth grinding, and a restoration should be loaded towards the central axis of the tooth, not away from the center, as to prevent the fracture of the filling. And the direction of the grinding can be established with the so-called scratch test. I haven't included the scratch test in my presentation. Next slide, please. So several reviews has been published to see the effect of sleep bruxism on the dental implant, and sleep bruxism seems to be unrelated to the biological complication such as failing osteointegration of the implant, but there are some evidence which suggests that the bruxism causes mechanical complications such as fractures of implants or supra structures or prostheses. Next slide, please. So coming to the treatment is usually multidisciplinary approach, which includes the dentist. If there are other medical conditions or substance use or the medications, so physician or the medical treatment has to be considered. In such cases, sleep physician review if we think any sleep disorder is contributing towards it, and the psychotherapy or the counseling also needed. Next slide, please. So intraoral appliances. So these are the hard occlusal stabilization appliance, And this appliance, they are indicated for the TMD pain as well as for the sleep bruxism, and it can be worn over upper or the lower dental arch. Next slide, please. So, there is no sufficient evidence to say that the occlusion splint is effective for treating the sleep bruxism, but indication of its use is questionable with regards to the sleep outcomes. But it may be that there is some benefit with regards to the tooth wear. Next slide, please. Okay, so if the patient has concomitant obstructive sleep apnea and the sleep bruxism, then oral appliances are useful. The mandibular advancement devices can help to treat both obstructive sleep apnea hypopnea syndrome and the sleep bruxism together. The oral appliances, or we call it MAD, are most effective in the younger and thinner patients with mild to moderate obstructive sleep apnea patients. They are less likely to be effective in the obese patients. And if the patients have any severe disease, custom-made titrable devices offer superior treatment and greater likelihood of success than other type of oral devices. Oral appliances are very well tolerated with the less serious side effect compared to the continuous positive airway therapy, positive airway pressure therapy, CPAP therapy. Next slide, please. So, if I want to summarize that how should we treat holistically the sleep bruxism patients? So, there are 5 P's. The first P is a prevention, the patient education in the sleep hygiene, relaxation, coping with the anxieties and the stresses, and avoiding risk factors such as the consumption of the stimulants is important. In medication-induced bruxism, a change in the prescription or use of a customized dental splint or the tooth protector is advised. Patient counseling is a training of the patient in the self-monitoring and the reversal of the behaviors and the habits. Psychological or the psychiatric intervention includes the stress management, cognitive behavior therapy, and the biofeedback methods. There are certain pills which includes the muscle relaxant, analgesic, anxiolytic, or the benzodiazepine, or the even botulinum toxin injection of the masseter and the temporalis muscle to reduce the muscle tension and the pain. Plates are the removable dental splints, almost similar to the customized retainer, and they are lifted over the both upper and the lower teeth, as we discussed. And the screen and treat associated sleep disorder, and the 2-jaw dental splints with the mandibular advancement, or a single jaw dental splint with the continuous positive airway therapy can be used to treat the OSA and the sleep bruxism concurrently. Next slide, please. So when the GP should refer to a specialist. So general practitioner may consider sending patient to be assessed and sleep tested for bruxism if patient has any frontal headache on waking up, orofacial or the masseter temporalis pain, temporomandibular disorder, GERD, daytime sleepiness, tiredness, and snoring, because these patients require the integrated multidisciplinary care. Next slide, please. So our take-home messages are: for a possible or probable sleep bruxism diagnosis, self-report and a clinical approach are sufficient. Whereas for a definitive diagnosis, we need the polysomnography with a extra EMGs for the along with the audio video recording to confirm definite diagnosis of sleep bruxism. REM-BD, RBD, OSA, and the GERD are the important comorbid conditions in the patient with the sleep bruxism with a possible causal associations. And the concomitant sleep bruxism with the obstructive sleep apnea is common. Although the true etiology natures of this disorder is not fully understood, there appears to be a modest causal relationship, and patient with the sleep bruxism and the OSA should be assessed for underlying sleep disorder breathing, as sometimes the sleep bruxism is treated with the occlusal splint therapy, and if patient has underlying OSA, it may worsen the obstructive events if it is unrecognized. In the clinical population, a higher prevalence of the OSA has been observed in the patient with the temporomandibular disorders and comorbid chronic pain conditions such as the fibromyalgia syndrome as well. And the patient who has idiopathic chronic pain conditions, they should be screened for the sleep disorder breathing and treated if as indicated. And the patient with the sleep bruxism and the symptoms of OSA should be assessed for underlying sleep disorder breathing. I think we just discussed this same point as mentioned above. Next slide, please. Yeah. So thank you everyone for spending your hour in the evening for me. I'm open to the question now. And sorry for the technical glitch again.
Yes, so thank you, Dr. Pandya, for delivering such informative presentation despite the technical glitch which we had earlier. You recover quite well. And now we are open to questions. So if you have any question, please drop it in the Q&A section and Dr. Pandya will answer it for you. There is one question which is, Doctor, what kind of splints would you recommend for patients suffering from sleep bruxism?
So we go back to my previous slides. So as I mentioned, there are two type of the before this you know the so intraoral appliances. So there are hard occlusion stabilizer appliances, and the next one, please. No, not this one, not this one. In the 5-piece slide. Yeah. So there are two jaw dental splints with the mandibular advancement or a single jaw dental splints. And I think this, if usually is treated by the my dentist colleague, and if there is any dentist in this CME, please help me to answer as well, because you guys are the front line for the sleep bruxism. Anyone?
Yeah. So can Michigan splint be used here for these patients?
Sorry.
Michigan splint?
Okay, so that's why
That's one
I'm
of the
telling that
right?
usually this is done by the dentist.
Okay. And how about Botox, doctor? Can Botox be
Yeah,
used?
Botox can be used for the temporomandibular joint dysfunction. Yes, that one I have mentioned in the for the masseter and the temporal muscle
Can you
tension and the pain.
advise the dosage, doctor, for Botox?
Okay, so usually it is not done by me, it is done by the dentist. So I'm not doing it myself.
Okay.
So that's why I'm suggesting, if any dentist in the audience, please share your practice.
Okay, doctor. Any other questions for us? The next question is for diagnosis. If we don't have the access to testing, which you mentioned, can we just send the patient for sleep study as dentist?
Yeah, you can. You can. And if you need any help, you can contact me. I can help you to arrange.
Okay. Thank you, doctor, for that. So you can contact doctor at this address. That's her email address and the handphone number. Okay. So with this, do you have any other questions? Please drop it in the Q&A section. Meanwhile, we will like to take the attendance for this webinar. So for that, I will pass you a QR code on the screen. Please do scan it and put in your details on that. Yes, so please scan this QR code and please fill in your details so that we can award you the CME points for the webinar. If you do have any questions for us, please drop it in the Q&A section. We still have 5 minutes, so if you do have any question, please type it in the Q&A section for us. And please remember to fill up your details in the form which is linked to the QR code. Thank you, doctor. Thank you, doctor.
Okay. So do you see the bruxism with the upper airway resistance? There are upper airway resistance, yes, because the pathophysiological mechanism we think is similar to the sleep apnea, but there is no major studies on it, but it's possible because they are similar, upper airway resistance syndrome and the sleep apnea. Only in the upper airway resistance syndrome there is no desaturation, there is no significant desaturation we can capture into the polysomnography. But when we look at their raw data and their airflow, there is significant airflow limitation.
Thank you, doctor, for that. Any other questions for us? Please drop it in the Q&A section. So we have the next question, which is, what are the affordable ways to get diagnosed with SB or OSA in Singapore?
Okay. So for the diagnosis of the sleep bruxism and OSA, we can do only two type of sleep study. Because the sleep study must include the electromyography, and apart from the chin electromyography, which is available in the standard PSG polysomnography, we need to add two more EMG channel to the masseter and the temporal muscle as well, to have the better diagnostic criteria for the sleep bruxism. And the type 1 and type 2 sleep study, they are exactly same, but the type 1 has some video recording and the sleep technology is observing patient same time, while in the type 2 there is no video recording, but there is audio recording, and uh, there is no sleep technologies is observing the patient. So you can do type 1 or type 2 study with the extra EMG leads for the bruxism. And the most affordable way, if they want to, if it can be done at home, then it's cheaper. But it's again, we have to go on to the patient insurance, whether it will cover or not, inpatient, outpatient. So, but cheaper is the outpatient compared to the inpatient. So any comments on the connection between parasite and bruxism? Sorry, Dr. Surinder, I'm not aware of this. So sorry.
Okay, thank you, doctor, so much for that. Any more questions for us? You still have a minute to go. Okay, so if you have no questions, please remember to fill up the form linked to the QR code. And with this, we stop for today then. Thank you for your time, Dr. Pandya. Thank you for your effort.
Thank you everyone. And sorry for technical glitch. Thank you, Dr. Ajay, for helping, organizing, and assisting during the technical issues. Thank you very much.
Oh, doctor, you
And
recovered quite well. Thank you so much for your effort. Have a good
thank
evening.
you. Yeah, good evening to everyone, and have a good rest in the night.
Thank you. Thank you, doctor.